All right, so we're going to go ahead and get started. First, I wanted to thank everyone for joining us this morning for this clinician crosstalk. I am going to be introducing our speakers and then kicking us off this morning. So, Crystal is a nurse scientist with a developing program of research in shared decision-making and patient preferences across the cancer center continuum. Unfortunately, she was unable to be here with us in person today, although she was instrumental in us reaching kind of this end project that we're presenting today. Ellen is the director of the Decision Science Center at Cincinnati Children's, where her work focuses on improving decision-making for pediatric patients with chronic conditions and their families. Semra is an expert in stated preference methods and shared decision-making tools. Her research focuses on understanding the decision-making process among patients, care partners, and clinicians, especially for chronic and terminal diseases and at the end of life. Peter directs the Indiana University Center for Bioethics, conducts research on patient decision-making, and practices adult outpatient general medicine in Indianapolis. And I'm a pediatric psychologist whose clinical and research interests include supporting the education and decision-making of adolescents and young adults with a difference of sex development and their families. Haoyang focuses on discovering gaps in patient-provider communication and building interventions to improve difficult medical decisions and return of non-medically actionable genomic findings, cascade genetic testing for cancer prevention, and pediatric goals of care. And so that is our panel here today. And we'll be presenting one of the first clinician crosstalks this morning titled Shared Decision-Making in Action, Real-World Cases and Challenges, or hashtag SDMIRL. And so we have no conflicts of interest to report. To orient everyone, I'm going to provide a brief introduction, and then we'll jump into a few cases. Related to the cases, some of you may have seen or participated in the activities set up during the poster sessions throughout SMDM related to this presentation. We'll get there shortly. But first, I want to first talk about shared decision-making, or SDM. And so this is a collaborative process where a clinician and patient actively engage in healthcare decision-making by first recognizing and acknowledging that there is a decision to be made, discussing the best available evidence on options and associated benefits and harms related to those options, and determining a preferred option by exploring the patient's informed preferences for option outcomes. And so SDM is considered the crux of patient-centered care. And there has been and continues to be a challenge between the gold standard of shared decision-making and then what implementing elements of shared decision-making can or may look like when we're integrating within clinical practice. And so the goal of this crosstalk is to facilitate discussion. That's why we asked you all to come to the front among clinicians and researchers. And we will utilize clinical cases to help support and generate this discussion today. And so as we go through these cases, to keep it more relaxed, we'll bring the microphone to you. So please just raise your hand, right? We will ask for engagement, but if you have a question or comment, raise your hand. When you speak, please first introduce yourself and your institution, and then let us know if you do have a clinical role. And also, if you feel a little bit more microphone shy and don't like public speaking as much, we'll also be monitoring the discussion in the comments section of the WOVA app. And so you can also use that as well. There's 3 separate cases that are posted, an opportunity to comment on those. And then we will move forward into our cases.
Hi, everybody. First of all, I just want to do something. We didn't plan this. How many clinicians who have a clinical role in the room? Okay, pretty good. About a third I'm seeing. Okay. So our goal is to have conversation which is very clinically real and is informed by clinical experience, as well as engaging all the research and the theoretical sort of things we do at SMDM. So I'm really excited about this session. I'm thrilled to kick it off. You've heard what we're going to do. Now we'll show you. So we'll engage you. So here's the case. You've all read it now because I jabbered on there for a second. A 55-year-old woman is seeing you for follow-up care for diabetes and hypertension. I will warn you, this is a GP case because I'm a general practitioner, I'm an internal medicine outpatient. So, but don't worry, the later cases will be incredibly complex and medically, don't worry. If you came here for that, oh, we have that. Okay, but for those of us in the room who do outpatient adult medicine or outpatient medicine at all, so again, after addressing these issues, you notice that while she's up to date on cervical cancer screening and breast cancer screening, she's never had colorectal cancer screening. As you may have heard in previous talks, maybe even by me, there are two main options: colonoscopy every 10 years, or stool testing with a test like the FIT or the Cologuard every 1 to 3 years. You tell her that she's due for colon cancer screening, and she says that she's heard about the colonoscopy, and she'll do that, like her husband did 3 years ago. You're unsure how much more discussion is warranted to achieve shared decision-making. Our questions for you are, what would you ideally do? What do you think is the ideal, proper response here to do good care, I'll say, more generally, maybe to do shared decision-making? What would you actually do? Do you think the ideal is somehow not what we're doing? And what do you think others would do? And again, you have different opinions maybe of how this goes in other people's clinics other than yours. We'd love to hear that. And you can start with any of those questions, and the mics are on. I'll be carrying mics for the other speakers, but the other speakers will carry mics for this one. Starting with Kristina. Yeah, go ahead.
Okay, maybe ideally you would say, that's great. I just wanted to make you aware that there are other options if you want to consider those. What people would actually do, depending on how much pressure there is to push colonoscopy, they might say great, or they may assume that the person has thought about it and that's the choice that they're going to make. And I'm not sure what others would do.
So what is ideal, though? Let me push you on that.
Oh, I would say maybe ideal would be to just make sure the patient is aware of the other options and to confirm that that's how she would like to proceed.
Okay, let's get some.
What? Who are you?
Oh, yeah, sorry.
Oh, I'm sorry. I'm Aisha Langford, Wayne State University, and I am not a clinician.
Okay. So she thinks it sounds like a pretty quick description of other options, but not going forward without talking about other options. Going ahead.
So I'm Bill Benish, retired internist from Case Western Reserve. And I think I would actually do what is ideal to do, since I would be influenced by what I'm personally comfortable with. And since she's personally comfortable with the colonoscopy, I think that's a reasonable choice, and I would want to briefly discuss the risks and benefits and alternatives, but probably very briefly. And what others would do would be, I think most other people would simply order the colonoscopy because they work in a medical system where there is not time to talk with patients.
Outstanding. More, thank you. We have two views on the table. Good.
Good morning, Wendy Ullman, University of Michigan, and I'm a genetic counselor, so thanks for making this session available. And as a genetic counselor, my first question would be, is there a family history of colon cancer?
Interesting.
Because that would definitely influence which test to do.
Interesting. So not just rushing forward, but actually slowing it down. Okay?
Getting a good history, yep.
Interesting. Other thoughts? We have two microphones going now, so you can be the backup. You can be on deck as well as speaking. Okay, we have some in the
Wong,
front. Oh,
Tufts Medical Center, academic general internist. I would take a very similar approach to Bill's as an academic internist, supporting her decision, but also asking if she was aware that there are other options and there's some pros and cons. I'd be happy to talk about those if she wished, depending on if she wanted to. I would hope that's what I would actually do. And I, like Bill, think others would just go with the flow and go ahead and check off the box.
Yeah. We didn't say how long it took to take care of her hypertension and and diabetes, right? It's 10 minutes in now. Yeah, go ahead. It's in here too. Okay.
Hi, L. Weaver, University of Utah. I would like to hear someone ask the question of like, do you have concerns about this procedure? Like, do you have any questions about it? And to kind of establish where the patient's at before like throwing things at them.
Okay. Do we have others here? Go ahead.
David Sandberg, University of Michigan. I'm a pediatric psychologist. One thing that I would inquire about is which outcomes are most important. So besides describing the various options, the pros and the cons, interrogating which is most important.
So interesting. So now we're in it a little bit because we have some very simple suggestions. Just mention there's other options, mention there are risks. We have a longer discussion with a genetic counselor saying, wait, let's talk about your family history. We have somebody else saying, actually, let's back up all the way and talk about your goals and what your goals are with saying you want a colonoscopy, which again, I think you're thinking maybe ideal, maybe actual, but certainly maybe ideal. Ideal in the picture of shared decision making, not always maybe what we see in clinic where people stop there and don't just, like John, order the colonoscopy. No, like me, like, okay, colonoscopy, job done. We're gonna move on now. And other thoughts on how deep and how extensive this conversation is gonna be, because there's certainly gonna be, maybe we have agreement there's gonna be more conversation, but how much more has not been really nailed down yet. Go ahead, Marilyn.
Hi, I'm Marilyn Shapira, and I work clinically in primary care at a VA medical center. So I would have to also bring into the mix that, you know, their preferred approach is to start with routine screening unless they were at high risk. Or, so I would have to mention that I'd recommend, you know, another option before colonoscopy.
Okay, now the game is afoot. We have a person who's saying not only do we have a longer discussion, they're gonna drive her, push her, nudge her, I'll be nice, right, towards fit, thank you. Other people who wanted to say, hold it a minute, colonoscopy is a great choice, but there are, you know, it's actually maybe a better choice for you. I'm not saying Marilyn said that, but something like that. Like, there's actually an easier thing. I hope you know about that, and maybe that's a better choice. Almost a push, no?
I would just say there are constraints from the healthcare system you work in as well.
More thoughts?
Do you know, unless we see some documentation that the patient was directly involved, meaning some knowledge questions, assessment of what is most important to them in terms of pros and cons, just as a clinician, reading the note and saying what happened is very misleading. So ideally, one would have some document be apart from the informed consent document to say that something really happened.
Yeah. It's interesting. Oh, we have the Dan in the back. Oh, sorry, somebody here. Thank you.
Hi, I'm Katie Geary. I'm a British GP. We have a completely different system in England, so screening is nationally mandated. We do FIT for everybody first. So if she came in asking for colon cancer screening as a colonoscopy, I would want to know if she got symptoms. So I'd want to know, is she bleeding? Are her bowel symptoms changed? Is there an imperative there that means that we've gone from screening to actually diagnostic testing? Yeah. But then I'm in a different system.
So we have another comment for FIT, or a stool test. Dan, or somebody else, Dan, yeah.
Dan Matlock, geriatrician, Colorado. I'd probably just order the colonoscopy. You've already addressed diabetes and hypertension, so you're probably behind. In 6 months, when she comes back and she hasn't done her colonoscopy, then I might dig in and say, okay, what's going on? What are the reasons there? But with 55 and diabetes and hypertension, she has much bigger decisions coming in her life later that will warrant a lot of shared decision making. And I think this one you can just kind of move on.
So only because I know and like Dan, I've got to needle him. So you don't even mention stool testing, Dan? Okay. Okay, we have our extreme one side position staked. We got people to mention FIT. We have people who want to say more or less about fit, maybe push towards fit. Now, are all of these, oh, sorry, we have another hand.
Oh, here. I just have an anecdote from, I'm a genetic counselor, and I have a genetic counseling colleague who was just sent the fit in the mail. It did not meet her family history. She actually had a very strong history of colon cancer, and so that was an inappropriate colon cancer screening recommendation for her, and she did not consent to it or discuss it with her physician.
I'm getting an echo, and I didn't even hear. In the back, my AV man, I'm going to put some pressure on him. On him. Notice, yeah. Thanks. I want you to repeat your comment.
Oh,
I didn't.
Sure.
In fact, why don't you put down the microphone and yell it for now until we fix the microphones?
Just for context, I'm a genetic counselor, and I have a cancer genetic counseling colleague who was sent the fit in the mail. She has actually a very strong family history of colon cancer and already had genetic testing, so that was an inappropriate screening method for her. She didn't consent to it, she didn't discuss it with her doctor. And if she had it, she would have told them that it was not appropriate for her.
Thank you for that. Okay.
Keep it in the mic.
Oh, I refuse. The mic is broken. Broken. Okay, no. Is that better? Can people understand me? Should I stand back? Is it okay?
No.
It's a problem.
It's a... People usually cannot understand. No, it's an echo. I refuse. Go ahead here, somebody. Is it here? Yeah.
Hi, I'm Sarah Bordenberg. I'm a pharmacist by training, so don't have a primary care background in that sense. However, I'm surprised one of the things that hasn't come up more is the conversation around needing to repeat the screening either 10 years or every 1 to 3 years, both from a patient adherence perspective, but honestly also from a health system perspective and ensuring we're, I presume, meeting clinical guidelines and standards of care.
Yeah. Okay. I also have been interested that so far, that's better, thank you. Way to go, thumbs up. That nobody's mentioned giving her a decision aid. I mean, we're the decision aid group, aren't we? Like, I've made them, why won't you give them my decision aid? Come on, 8 minutes, tell her to wait, sit down, watch it. That would cover all these things. But interesting, nobody even raised that actually as something on their minds. It's just maybe it's not available. I'm sorry? Documentation. You would like that for documentation? Okay, love it. More thoughts here, yep. Oh, this is much better.
Back again, another comment is suggestion made by the psychologist in the first row, which is if I would be influenced by modern technology and whether my conversation was being recorded and whether the algorithm said risks and benefits discussed or whether it gave the specifics of the discussion.
It makes me happy and sad, right? Because we'll never break through to get risks and benefits discussed until we're forced to, but boy, the listening ears and the walls, that's just what we want, right? Fascinating. Okay, so actually, am I at time? You have to tell me the time. I think we're close. We have to have time for all the cases. 2 minutes to finish up? Or keep rolling. Okay, I'm going to roll. So where are we? The other questions I had was somebody said mentioning, I think John mentioned from the beginning, mentioning risks of the colonoscopy before moving forward. I wondered if that meant saying the specific risks, like just so you know, 1 in 1,000 people will get a perforation from a colonoscopy on average, maybe 1 in 10,000 or 2 in 10,000, and 1 in 1,000 will end up in the hospital with that bleeding. Should we talk about your other options? Or is it just this general idea, look, there are 2 options, very basic description of the 2 options, not even specifics, possible adverse effects of colonoscopy, and just making sure they know about 2, and we're done. We can say at least some risks and benefits were discussed. Not like you'd get a decision aid with lists and maybe even numbers of how often they happen, but just naming them. And we're just sort of trying to have a discussion today in each of our cases about how extensive do we hope to go? Where are we as researchers being maybe too demanding or maybe unrealistic? Where are we as clinicians sometimes being not demanding enough in the nature of the conversation? So any other thoughts here on where we should land? Yep, here.
The one other variable that hasn't come up in the discussion is what's the test sensitivity, both with Cologuard and with the colonoscopy. And then that's going to factor into what is your risk, baseline risk to start with. Are you the same as the general population, or is your risk elevated?
Yeah, see, that's why I hate genetic counselors. No, just kidding. What I mean is you have an hour, half an hour with each of your patients, and you're right, that is a wonderful thing to review. You can miss, there's actually a specific risk rate, for a fit, not getting every cancer or advanced polyp even. But I think the clinicians here, none of them suggested that. And here we are in this tension, right, of how far can we go? We'd love to go farther, but wonderful. Okay, I have to try to wrap it. I will tell you that one reason I got involved in colon cancer screening as a research topic was that my friend who does endoscopies at IU has every week at least one patient who comes in, and he, as a good endoscopist, says the alternatives before they start their colonoscopy. And he says, well, you could have been screened with a FIT. And they say, hold on, doc, nobody told me there was an alternative to this. And he says, well, do you want to go forward or not? And he carries a $20 bill. He says, I'll give you $20 to walk out and go get your FIT if that's what you want. And he's never had a patient take him up on it. They say, I prepped, I'm going forward. So anyway, shared decision-making as a goal, as an actuality. Next case. Okay.
Well, and to integrate some of the quotes and feedback we got for the poster that we had up, right? Here were some things mentioned, which I think we've covered a lot of this and pretty consistent in terms of like ideal actual versus like what might others do.
Great. I'm going to preface this case by saying that Peter said this one was really complicated, which I think just reflects that he's an adult internist, not a pediatrician. So a 15-year-old patient who was diagnosed with ADHD and has been on medications for several years and wants to stop the medications. They've been getting good grades and there are no current behavior concerns at school or home. Parents state that the patient, quote, doesn't remember how bad it was before they started medications and wants the patients to continue them. So that's the case. I realize we never put in this other question, but for those of you who are more in the research space, I think it's also worth thinking about like, what does the research say we should do in different cases? So feel free to bring that perspective as well. So what would you do? Or what would others do? Or what would you do if you treated kids? Thanks, David.
I mean, decision-making starts with good evidence, good knowledge. And so the parent should be aware that strong evidence suggests that after 2 or 3 years, the effects of stimulants wear off.
Yeah, so thinking about maybe the kid's right and that it's time to stop medication.
So Brian Zickman-Fisher, University of Michigan. I mean, I'm a risk communication person, but it seems to me like I would immediately start with the question that I think everybody's wondering, which is, okay, yes, it's possible that there will be some form of regression in terms of behavior, in terms of grades, et cetera. How likely is that? Because the conversation is really different if that's a very likely event versus if it's a very rare event.
Great, so giving some information both about what statistically, what the evidence shows about treatment and length of treatment and what happens when you stop treatment.
Hi. Oh, sorry. Hi. My name is Mariam. I am a researcher at University of Michigan, but I'm an incoming medical student at Michigan State University. So some clinical background, but not really. I think the biggest thing would be in an ideal situation, there's 2 people involved plus you as the clinician in this dynamic because it's a pediatric patient and eliciting what the 15-year-old wants, because that's kind of like a middle age of sort of like developing autonomy and trying to figure out like who you are and how you feel on the meds as well. And so trying to elicit the preferences of the patient and why do they want to stop meds, as well as trying to understand why parents are hesitant and sort of figure out that dynamic a little bit and get more information before you dive into this is what we can do and what we probably shouldn't do.
Great. So thinking about the goals and preferences of each group. If you want to go into pediatrics, come talk to me.
Hi, Emily Coulter-Thompson at University of Michigan. I have a social work background and a family situation very similar to this. And building on what you just said, I immediately thought, what does the patient want? And why has the medication been bothering them? Like if there are side effects that they notice, what is that experience like and what has changed? Because really, you can't force a 15-year-old to take this medication. So you have to have buy-in at the end of the day. So I think you have to have that partnership between the adolescent and parents for it to work.
Thank you. So emphasis on the partnership between the parent and the adolescent.
Katie Valentine, Mass General. I love the what y'all just said about finding out why they don't want to be on the medication potentially anymore. I think if clinically, not a clinician, definitely not a clinician, just work with them. I think if it's clinically appropriate to trial taking it off, I'd want to set realistic expectations with them about what that might look like and discuss at what point they would be willing to go back on the medication and what kind of outcomes we would have to hit that they would be concerned enough to come back on, and make sure that the child agrees with what that looks like so that there would be potentially less of a barrier to coming back on the medication if they did need to come back on the medication.
So Katie's adding in not just having buy-in about taking medication, but buy-in from both parties about what are our goals and outcomes, and how would we know if coming off the medication worked? Or potentially staying on the medication was, how do we know that outcome is working?
Aisha Langford, Wayne State University. I'd also be curious to know if there are other alternatives, either other medication for whatever reason the person maybe doesn't like that one, or is there good evidence about like behavioral strategies, mindfulness, other like monitoring that the child may want to do or be appropriate to do that might be a good medium? I don't know the evidence, I'm just curious.
Yeah, so exploring what the problems are with the current treatment, and so that you could think about what alternative options are to meet everyone's goals, like that. Dan.
Yeah, Dan Matlock, Colorado. Kind of like the last case, in primary care, one thing that's nice is you don't have to do everything today. And so I don't treat kids, but this reminds me of like an older adult wanting to stop a depression medicine and maybe their kids don't want them to. You can kind of do a time-limited trial. Like Brian's question, what is the risk? You may not know what the risk is, but you can say, well, let's try it for a couple months and then come back and see how it goes. I do think this is a situation where a lot of shared decision-making is important. They're great comments, but you also don't have to solve it right today.
Yeah, so the decision doesn't have to be an event, but is a long-term process.
Hi.
Sorry.
Can you hear me?
Yeah.
This is Hina Wasim. I'm a neuro ICU doctor at MGH. So one of the questions, everyone said some amazing things, like the whys are so important. I think one of the other things I would be interested in is understanding the patient and the parent relationship. Like, is this a teenager who's like very like, has a good relationship with their parent, those teenage years, like understanding the dynamic between the two, because we can set all these goals and it could be great, but if the parent and the child don't follow it after they leave the clinic, it's not very useful.
Mm-hmm. Katie Bauman, I'm a neonatologist here at the University of Michigan. Kind of building off of all these ideas, I think it's important too to have a discussion just with the patient, with the parents outside of the room. And then you can understand a little bit more if there's things they don't want to say in front of their parents. Obviously, it has to be an ultimate decision with everybody involved, but to really understand the dynamic, you need to talk to the patient alone.
Great, thanks.
Hi, I'm Haoyang Yang from Auburn University. I have trained in motivational interviewing a little bit. In this case, I would like to point out that I would like to appreciate the teenager patient that bring this topic up. She or her is not just dump the medicine into a trash or sell on street to other kids because it can lead to other problems. And yeah, that's it.
Yeah, so starting with a kind of validation of the patient, bringing forth the question rather than just stopping on their own. I think we'll take 3 more, maybe Marilyn, and over there, and then John, and then we'll be done.
Yeah, John Wong, adult internist. In contrast to Peter, I do see patients who are adults who are coming with these symptoms and asking about this, mostly to asking whether to start. I completely agree with trying to understand the context for the patient in terms of why, and then a discussion of perhaps a trial, as well as are there things they would be worried about. But the one thing I have to add perhaps is that there are these symptom inventories that help you assess what their current functional status is with ADHD.
Right, so you could get some evidence-based data on which to make decisions. It doesn't just have to be perceptions of the parent and the child.
Oh, okay. All right. Marilyn Shapiro from Penn and the VA in Philly, also not a pediatrician. But I'm wondering, from the clinician decision support point of view, we're talking about pharmacotherapy, so perhaps a formal decision aid in this, or sort of option grid that shows you the alternative pharmacotherapies could be helpful for communicating alternative options, and also, providing the physician with some options.
Yeah, so having a tool to help discuss the options, both so the physician has them at the top of their mind and so that they can share that information with the parent and patient.
Hi, Sarah Bordenberg from the University of Michigan again. So I get that the 15-year-old is on the relatively young side to make independent decisions, but I see students as they're in college. I teach college students, and the number of students that show up and say, I stopped my medications after the first few weeks of class because now they're on their own and feel like they are now empowered to, makes me wonder if we should give the 15-year-old as much power as possible to make a decision in a safe setting where they're presumably still living at home, have oversight, and then we can go from there and use that data for that period of time.
Yeah, so thinking about, I think I love all these comments, but I think we're gonna stop so that we have time for all the other cases. Sorry, but we hope this conversation continues, but I like that about thinking about where is this patient developmentally and where are they headed and how can we foster that development. So before we wrap up, so these were the ideas that came up on the poster over the last couple days. Give them the Cincinnati decision aid. I'll tell you, the truth is, and I think this is where we get to like SDM in real life, which is that the Cincinnati decision aid is not actually used that much in Cincinnati even, because it's hard to get decision aids into practice. One person said what they would actually do is listen to the parent and just continue the medication, which then raises the issue that someone brought up of like, maybe the kid's just gonna start throwing out the medication and not taking it. So to wrap up this, I think there's a lot of discussion about both how we provide evidence, just as there was in the discussion about colon cancer. There was a lot about how we build partnership between the parent and the patient. And I'll say in this case, that's the partnership that needs to be built. There are other cases of triadic decision-making where, at least in pediatrics, where the parent actually takes the role of building the partnership and helping with the understanding between the clinician and the patient. So it's in a triad, the different roles may vary based upon both the people and the decision that's at hand. And so I think that flexibility is important. What I noted is that aside from the comment about there being validated inventories to assess symptoms, no one said, well, the evidence says that the best way to approach this decision is XYZ. And that's not surprising because there isn't clear evidence. And this is part of what the discussion needs to be in terms of how we bring everyone, clinicians and researchers together to build that evidence base of how best do we engage people in making decisions together. And I will also the last thing I want to say in here is that I think it's important to note that pediatric, so throughout this conference, there's been discussion about where does shared decision-making fit in clinical guidelines. And what's interesting is that most of the clinical guidelines, at least that I could think of off the top of my head last night, in pediatrics that talk about shared decision-making do not explicitly say who is sharing in the decision or to what extent the patient is sharing in the decision. And so even in that very pediatric-centric space, we have a long way to go to think about how we build these decisions. And with that, I'm going to turn it over to Semra.
So I think this is maybe the most complicated case Peter was referring to. So we have a 75-year-old woman with pancreatic cancer who has gone on multiple rounds of chemo over the last 2 years. While there was some initial response, her cancer has progressed and treatment has taken a severe toll. She has been hospitalized several times, now spends most of her time in bed with significantly declined health. After a recent admission for weakness and poor appetite, imaging shows widespread cancer progression. The oncology team suggests a new treatment that may slow the disease, but the benefits are uncertain, and the side effects could be harsh. So her daughter and son disagree on the next steps. Her daughter, who has been closely involved in caregiving, believes it's time to focus on comfort and support their mother in transition to hospice. Her son, who's visiting out of state, wants to pursue further treatment. He believes their mother would want to keep fighting. Both believe they're honoring their mother's wishes, leading to growing conflict within the family. So my questions are the same. What would you ideally do? What would you actually do? And what do you think others would do? Wow, everybody is taking, okay, a minute to, great. And can you please remember to introduce yourselves before and let us know if you have clinical role.
Wendy Ullman, University of Michigan, and again, I'm a genetic counselor, so not the physician that would be treating the patient, but as long as the patient has capacity, she should be able to make her own informed decision, and would also consider getting an ethics committee consult involved, given the conflict between the children here. But as long as she has capacity, she should be able to make her own decision about her next steps.
Okay, great, thank you.
Hello, Francesca Williamson, University of Michigan. I think after going to a session yesterday, I would request an ethics consult who could support facilitating shared decision-making and making sure that everyone in the situation is heard.
Great, so we're hearing ethics council coming up. Any other opinions or yeah.
This is Hina Wasim again, a neurocritical care doctor. So this happens a lot clinically every day, and sometimes the patient can't even express their wishes if they don't have capacity. And family members will have a lot of conflict around what the next steps are. Fortunately, hopefully this patient can express their wishes. And I think before escalating to ethics, in reality, like in clinical practice, we would probably not escalate to ethics right away. We would actually try to, one, understand if the patient has capacity to make their own decisions. Let's say they don't, like kind of like the pediatric case prior to this, we would actually really have invoke the values of the patient from like substituted judgment from the children. So not talking about their wishes per se of what they want for their mother, but really be like, if your mom was sitting right here in this room, what would she say in this situation? And what are her values? So going a step further and understanding what was important to her. Also understanding if she had advanced care planning. Like maybe she already did. Maybe she had a living will, something that already told her kids what she wanted. And now they're kind of more focused on what they may emotionally need at that time. And so I think invoking values and then really trying to mediate. And then also understanding the state laws around actually who would be the legal decision maker in the situation. Because it does vary by state, which is real fun. And sometimes it's not clear. And then you have multiple decision makers that you really need to mediate. Sorry, it took a little bit longer.
Thank you, Hannah. You had so many great points, definitely.
We see this
not
every
rushing
day.
to a decision right away to this is one of those cases, you may have a little bit time and you may want to wait to see what if the patient wake up and be able to express their preferences, also looking at ACP documentation, right? If there is any wishes expressed before. Okay, Dan?
Yeah, sorry to speak again, but this is a stimulating discussion, so thank you. So I'm also boarded in palliative care. I would not escalate this to ethics. I think this is just time for a sit down and a long discussion. And I do think aligning it to what their goals are, letting the kids hear the goals and see if you can get everybody on the same page. Escalating to ethics could create confrontation. that you may not need. That should be a rare solution for something like this. This is bread and butter care at the end of life that many of us will face with our families.
Yeah, yeah. So a family conference and discussing with the family, yeah. We have
Katie Bauman again, University of Michigan, neonatologist, but also bioethics trained. I think these last answers have been really wonderful and covered so many things. I think the best first thing is to sit down with the family and really have a discussion, because a lot of times these are just communication issues where somebody doesn't understand what the treatment options are, really understanding why they're saying that they want to keep fighting or not, understanding those values, and then trying to understand what the patient would have wanted if they can't participate. Anytime somebody is uncomfortable, an ethics consult is great. Definitely support that, but this might be solved by having a family meeting with everybody in the same place at the same time.
Great.
So I'm David Meltzer. I'm a general internist and an economist. As a general internist, I still see primary care patients, but I'm also the chief of hospital medicine. So I run the group of hospitalists, and hospitalists find themselves in this role all the time. And what I would say is that there's a system problem that even precedes this, which is that this is someone who's been going in and out of the hospital with their care getting worse.
Yeah.
And it's unclear how much discussion there's been between, almost certainly there's being seen by different doctors all the time. They could be oncologists, they could be hospitalists, they could be both. It's unclear what sort of real conversation there's been with the family during those things. And almost certainly the doctors caring for her in these hospitalizations have had no understanding of the broader family context. So one of the things that we've done, and what I think ideally one should do, is try to develop more integrated models of care that connect inpatient and outpatient care for these really sick patients. And so we have something called the Comprehensive Care Program, where we have a small group of doctors who only care for patients at high risk of hospitalization, so they can care for them in and out of the hospital. And one of the things we really emphasize with them, that it's not just the patient, but it's the family members and the whole family members. And one of the nice things that comes with continuity is that when you see patients in clinic where you often only get one parent, but you also, or relative, but you then also see them in the hospital, you very often, particularly over time, get to know the whole family better. And so I think that really helps address some of these issues. And I'll say that I work with a sociologist named Alex Tate, who's been analyzing our data on advanced care planning. And one of the things that we're seeing is that these conversations are happening much, much earlier. And we have a randomized trial that shows this. And so I think my big comment is there are deeper systems problems here. And yeah, you can deal with it on the back end, but there's also an important component about thinking prospectively about how to organize care. And then, finally, how is it that we get to a point where this is what care looks like? What do we need to understand about the policy drivers that produce this?
Great, great.
Hi,
Thank you.
I'm Dan Wiener, thoracic surgery from Boston, from the Brigham. And I really appreciate your comments about sort of this comprehensive, care team, because I think, first of all, it's always the son from out of state, right, from the other side of the country who comes in and changes the decision. But I will say that, even the way you sort of frame the scenario, right, the oncology team has already suggested this new treatment, right? They've offered this glimmer of hope, right? And so some family members always hear that, it may only be 1 in 1,000 chance, but we want to jump on that. And I think the opportunity to sort of engage in this conversation has to start at the very beginning, and you're often having to sort of rewind a little bit and step back, and that's where I think you end up with a lot of problems.
Yeah, great.
Tom Valley from the University of Michigan. I'm a ICU physician. I think I totally agree with what everyone said in terms of incorporating the patient into the discussion. I think our primary duty in this case is to ensure that the patient is able to voice their preferences moving forward. I think another element here is the fact that this woman's going to die, right? Whether it's sooner or later, she's in the process of dying. And afterwards, the siblings are really just going to be left with each other. And I think an important role here is to make sure that they can come to an agreement, right? That it's not one person railroading another person into a decision. And so, you know, if it must be, like, giving them the time to come together and make that decision together.
My name is Clayton Hicks. I'm a medical student at Indiana University, and I think this is often like the daughter being the caregiver, some from out of state, and it elicits this response of, oh, the caregiver understands the patient more and things like that, which very well could be true in this case, but I think it's important to make sure that you actually don't take that bias into conversations with the two of them, because there could be all sorts of things that the daughter is going through being the caregiver that might be swaying her away or towards the mother's wishes, while the son out of state could have very valid reasons for those beliefs as well. So I think just reading this, like, I understand my bias very quickly to be, oh, the daughter that's a caregiver is almost certainly going to be more likely aligned to her mother's wishes, which could be the case and very well could also not be the case. So I think it's really important that understanding that that relationship's important, but not be the primary factor in understanding who understands the mother's wishes in this situation.
This is Nan from University of Florida. So I will provide some perspective for patient because it reminds me my personal experience at some point in my family. So I think in this case, over past 2 years, this lady already have the chemotherapy. I think at some point they had this type of conversation. What they would do that her values is very important. And another thing I would bring up is her daughter is the major caregiver. So I would think when the patient doesn't have the capacity to make the choice, to make the decision, then their major caregivers, they carry the responsibility to take care of them. And also their quality of life is really matters. So when I was in this situation, I just talked to the major caregivers. I was like, I full support what you have made, what decision you made, whatever decision you made, because you are the major caregiver. I probably just came back once a while, and I don't really take care of her day and night, 7/24. That's a really big burden for the caregiver.
I actually have a question for Peter. Referring to an ethics committee has been qualified through the discussion, but I'm just wondering, what is the training that ethicists get in conflict resolution? I mean, they can talk about the ethical principles, but should we count on them to be able to resolve the emotional states?
Right, I'll take the question, although I don't really have real full expertise in that. But I like the comments that this probably isn't quite yet at the ethics committee referral time, because I think a lot of the clinicians here can run this kind of conversation. Like Dan said, it's time for a sit down. Ethics committees don't bring some God's eye view of what's the right thing to do or to resolve this family conflict and complexity. They have experience, some do get trained in conflict resolution, and they have been in these situations before, even worse, right? So in some ways they could be helpful, but when to call them and when their expertise could be helpful is a complex question itself. And often, as people know, the ethics consult committee won't give you an answer. They might tell you the range of options and say you should offer this and not offer that, but they won't probably solve this one for you. But thanks for asking. I guess he's saying because I'm an ethics background person. I run the ethics center, so go ahead.
Wasim again. Sorry. Two comments. One about the ethics thing. I think at least in clinical practice, there's a range of clinical ethics that get played in. So when we call ethics, it varies. So I've had ethicists actually sit in on family meetings depending on how high stakes or how complex situations can be. And they tend to be multiple rounds of complex conversations. But this is pretty straightforward. So there's definitely a range of how involved clinical ethicists can be involved depending on the issues. But going back to something one of our other providers was mentioning about the root causes of some of these unfortunate conversations that come up around these complex patients. One other just comment to note is people have mentioned how the oncologist is like, there's another treatment. It's unfortunate, but at times the physicians themselves might not all be on the same page, just like the family. And that just adds another layer of issues to manage when an oncologist, a primary care physician, and maybe an inpatient hospitalist are seeing 3 different perspectives and 3 different points of time on the patient. And unfortunately, having that outpatient primary care doctor who has a great relationship with the family and the patient is ideal and is rarely happens. So I think getting all the physicians on the same page can also be challenging, including inpatient and outpatient oncologists who might be involved in the family's care. So sometimes even the oncologist might be different. So it just, another comment of how broken things can be sometimes in communication.
So it's John Wong again.
She just said most of what I wanted to say, but the one thing I wanted to emphasize is, this is a really great point to document the patient's wishes and their preferences so that when they're going and getting passed to like oncologists and ERs and as they're going through this really complex network of care, that they don't have to state their wishes over and over again and that it's easy for providers to kind of know what their wishes are. And also to be able to do things like, if they can't walk, that they can get the care that they need in going in and out of these care environments.
So as a primary care doc, I try to fill in some of the gaps in a system deficits. And when a patient has a serious illness, such as a cancer, I'll usually sit down with the patient while they're in the hospital. I don't want to deprive them of hope, but I do frame it as, I'm hopeful that this particular therapy will be helpful for you to live longer. But as you know, there's sometimes adverse effects of these. And as you go on this, they're going to suggest, I'm trying to frame what's going to happen at the slippery slope with multiple treatments. And then I try to frame it at some point where, we're all hoping that you live longer, but at some point, being comfortable becomes more important than trying to live longer. And as each therapy is given, your cancer is a little less likely to respond. And so one of the important things that hasn't come up is talking about prognosis with both the son and the daughter, to be very clear about that. And having had a relationship where that discussion has occurred early on with the patient, hopefully when they were still cognitively intact, about their values and preferences towards the end of life with advanced care planning and that balance of benefit versus harms. And that context of that long relationship can be helpful for both the son and the daughter to help them make a decision.
So Brian Zickman Fisher, University of Michigan. I want to reinforce right from the start, I'm not a clinician. But just to follow up on what you're saying, John, I want to take a moment and pause about the assumption that we need to offer hope. Like, this is a moment, we all know this patient is dying. When Victoria and I and others have been thinking about the use of narratives, one of the things that we've pivoted towards repeatedly is realistic previews. What is the realistic description of what is in for? You brought up the question of prognosis. That's very well relevant to this. We've heard in many different contexts about how uncomfortable many clinicians are about talking about prognosis, about bringing that up. And I understand from a personal perspective, from a mental health perspective, that hope is valuable, but so many of these situations are really about acceptance of what is the reality, what is the trajectory that somebody needs to face. And so I just want to bring that back up into this conversation, because sometimes everybody wants to be hopeful, but what needs to happen is not necessarily looking at the rosy end of the spectrum, but the true, most likely, or even what the worst case scenario might be.
So Brian, just to be clear, I'm talking about the very first time they're diagnosed. They haven't even received a treatment yet.
Fair.
So in this particular circumstance, I would be much less hopeful.
Yeah.
And attempting to be realistic about the benefits versus the harms, just to be clear.
Okay. Sorry. Hi,
I'm Chetna Malhotra. I'm from Duke and US Medical School in Singapore. So I'm trying to put this case study in the context of Singapore. And it's slightly different from the US context because it's a very family-centered decision-making context there. And especially as this is the case for an older adult, collusion is not uncommon in Singapore, so which means that there might be collusion between clinician and family where patient is excluded from decision-making. Patient may not be even be aware in some cases about their prognosis. So as a clinician, there is some duty to find out what's happening, whether the patient has been involved in decision-making, especially if they're seeing this patient for the first time. Does the patient understand about the prognosis if they have mental capacity, assuming? If they understand their prognosis, what do they hope for? What do they fear? Is there some kind of denial? Again, involving the family. We've all talked about it, in having a family conference, involving the family. What are families' worries, fears? What do they hope for? Is there denial? So trying to understand the family situation.
Just to kind of go off of Brian and John's conversation, I think when we say hope, that's like, we need to define what hope is. Because like, hope doesn't mean I'm gonna survive my cancer. Hope might mean like having a peaceful death surrounded by family in your home. That might be the hope that they're looking for at the end of their life, is the quality of life, not hope that they're going to die in the hospital under lots of other issues. So I think when we say hope, I think like best case, worst case scenario that our primary care physician was talking about is that's what we elicit, and what our friend from Singapore was also saying, the hopes and fears of that patient's expectations. It might not have anything to do with cancer survival.
Okay. Speaking of Haoyang. Yes. Yeah, I do have questions. It's like people are asking what should do. I'm thinking about who would be ideally doing that and what's the time range you expect this kind of conditions will take for physicians to do it, the medical care team, how much time they are willing, they actually have to have this conversation and then to make the plan. I do want to know that.
This has been a lovely discussion. It's just like so many things. Like it's from this end of life cases, it's not really about, one thing I keep hearing is like, it's not about just the patient, right? It's about family. It's a very emotionally loaded situation. And as one of the commenters mentioned earlier, you know, eventually the patient is gonna pass away. It's a matter of time, and then it's the siblings left. And it's about there's bereavement and the grief, like how they're going to experience it. So it's not about, it's very much about peaceful dying for the patient, but also the peaceful dying for the patient so that the caregivers can handle that grief and the bereavement process. So it's a quite complicated case in that sense, because we're not talking about the patient quality of life, but we're talking about the caregiver quality of life. And they're the ones who's going to be left with whatever happened. And then, as a few of you mentioned, it's not just about actually just patient and the family, it's the whole healthcare system. There might be gaps in the healthcare system that we should look into, like documentation, ACP, who's the proxy? So I heard really, like, we had great discussion, and we also, there was, you know, prognosis, like, did we discuss about different treatment options or the oncology, potential conflicts within the physicians, right? Oncologists may want to continue treatment versus palliative care physicians may have different opinions. There might be conflict within the provider teams as well. And also, mention of the prognosis, like did anybody talk about prognosis with the siblings, with the patient before they were incapacitated? And we talked about cultural differences, you know, the culture, because this is such an end of life, it's very spiritual as well. And you know, it's not just your culture, your religion, your spirituality gets into the decision making as well. And we may see differences in Asian culture versus US culture. So this was great discussion. I think I need to wrap up. But this has been lovely, and I will pass it to Haoyang.
And also to integrate some of the quotes again, a lot of similarities, some slight kind of differences or suggestions noted as well, but we had some, just to highlight some of the quotes from the discussion that came up for the poster. And then this is a word cloud from all of the quotes that we got on the poster all together, just to kind of showcase what were some of the themes that were coming up more frequently in the thoughts. And again, very similar to the things that have come up during today's discussion.
Thank you everyone for a great discussion. I'm going to skip this slide and let's go to takeaways. Oops. No, it's the thing there. So, what are some key takeaways from the audience? You can raise your hand from the session. What have you learned?
So Darren Zaronick from the University of Michigan. I really love the discussion of the third case, particularly for this society. And even though I'm a clinician, I'm going to bring this back to the research perspective and what we do at SMDM. Because I think we all agree that this situation happens very commonly. And yet there's also been discussion in this meeting about, our scales and what we use to measure these things. And as someone who does both clinical care and research, I'm struck by the fact that we don't have good ways to measure what is a good decision in this setting. And I would just, I don't know that I expect anybody to answer this in 2 minutes or less, but it's something I've been thinking about a lot, that what can we do, because if we can't measure what's a good decision in this setting, how can we actually then try to improve it? I think we all recognize there are problems with how it's happening, but as a society, maybe we can also start to think about how we'd measure these decisions in these really challenging end-of-life scenarios.
Mm-hmm. My name is Clayton Hicks, a medical student at Indiana, and I sit here and think about, especially the clinicians in the room that have a high interest in shared decision making, and myself being a medical student, obviously haven't gone through residency and clinical practice, but how do you change culture within clinicians that aren't sitting in this room and really care about shared decision making to actually have it make a difference in healthcare systems? Because you can make all the decision aids you want and have modules on training for shared decision making, but if clinicians aren't properly trained in how to do it and don't care enough to seek to do it, there's a big culture that has to shift in how we talk about making medical decisions. I've experienced in medical education, it's often talked about, I've heard well, there was paternalism and now we're in shared decision making. And it's okay, that's great, but what does that mean in terms of how that's taught to us in, I'm talking specifically medical education for physicians, but I think all healthcare practitioners, I just think this is all great, but how do you actually bridge the gap? And I don't think it's just communicating the tools. I think it has to be about how the style or the way or whatever you want, how medicine is, as a culture, is taught to clinicians, which I think there's no easy answer for that, but I think that's a really big barrier in uptake of anything to do with shared decision-making, tools, metrics, scales, in terms of what actually happens in that short clinical visit with a patient.
Mm-hmm.
Yes. Hi, Eliza Ennis, PhD student at Stanford. I think for me, the takeaway was that there's so many different approaches from different clinicians, but it's all limited by time. And that we need to think about ways in which we can have implementation outside of that limited time period that clinicians have with patients. So whether that's having community health workers share decision-making tools and information before patients are entering their appointment, or if it's about having continued care, especially in the sort of specific provider spaces. So oncologists and genetic counselors may have more time with their patients than family care practitioners. And so thinking about ways in which we can have our tools implemented in those spaces where there's more time with patients to be able to have these full discussions.
Dan Wiener again. Just a quick question. Given the interactive nature of this session, I wonder, this may be inappropriate, so feel free to tell me not to, but with regard to that last scenario, and with reference to the question of how do we measure what is a good decision or maybe what is a good decision-making process. I guess I would just ask, like, how many people in this room, right, raise your hand if you think that patient should not get chemotherapy and should be focused on palliative care and comfort and, right? And so, you know, we all as clinicians, as patients, as family members, we all bring our own biases to this. And I think it's really hard to tease that out from a preconceived notion of what's a good decision and sort of how do we measure the actual process of decision making for that family and how subjective that is. Anyway, just
Eric Stone, Wake Forest University. I'm a decision scientist, not a clinician, so I'm coming at it from a slightly different place. But one thing that just struck me with all of these scenarios was how much the science matters. So we've talked about a number of psychosocial factors, and I completely agree these are all important, but I do keep coming back to the fact that some of these, the actual numbers, the actual risks and benefits and the probabilities are absolutely crucial for making high quality decisions here. Thanks.
Hina Wasim again. Sorry, I apologize for having so many things. I'm so passionate about this, but one of the other things that I think that is to comment on the time component and the practicalities of being in healthcare and medicine is I think we sometimes narrow and limit our scope to just physicians, and instead of looking at all the other people that can assist and help actually maybe even be promoting shared decision making even better in the healthcare field, like nursing leadership, nurses, social workers, case managers. There is a whole host of other people in the healthcare system that have more training in social science, have maybe perhaps more time, and can be potentially even more invested in the patients because they work with them in a different context and can be great patient advocates. So I think when we limit ourselves to just researchers and clinicians and not think about all the healthcare workers out there who can help with shared decision making, I think we're missing a great opportunity.
Building on what you just said, I think that we should recognize the fact that many of the things we're discussing are the human condition. And medicine doesn't have the authority to speak to the human condition in general. So it could be a religious leader, you know, outside of the hospital. You know, what would be I'll stop there except to say that we tend to view everything in terms of our individual specialties. If you're an oncologist, you're thinking of a medication. You're an endocrinologist, a hormone, et cetera. And that doesn't speak to necessarily to what people need. And I think medicine has been marketed as curing the human condition, certainly in Western countries. And I think we have to get, and I'm not thinking of more professionals, you know, psychologists. I don't think that's necessarily the remedy. People have to get back. How have people, in evolution, how have we sort of managed to deal with uncertainty, with grief, and we're just ignoring all of that wisdom.
Thank you, everyone. There's one more. Okay, one last one.
You asked about what we've missed, and I'm coming at this as like a sociologist and not as a clinician, and so I just wanted to raise a point, and it's not fully formed in my head, so I apologize in advance. But one of the things that I think people really struggle with, particularly around medicine, is making mistakes and leaving space to like recover from making mistakes, particularly because the patient bears the burden of all of those mistakes. And so the risk that I think about in a lot of these discussions is like, what's the risk of getting it wrong? And is the clinician thinking about that? And because the case studies that I've looked at that are really interesting are just where like the clinician has just gotten it wrong, and it's just because they were busy and overworked and they had a million things going on, and they got one of the details wrong, and then things fell down the stairs for like months, if not years afterwards. And so that would be one of the things that I would ask to include in this discussion.
Thank you, everyone. Beautiful summaries. You summarized it for me. So there are several key things that emerge from the discussion, from things that we already know, that we know we're doing, giving information, pros and cons, options, talking about outcomes, and also like looking at individual factors, the motivation, their capacity and values, to that social context from who's sharing the decision, family, patients and doctors, and also like the cultural context to like utilizing the resources. So what really strikes me is that we have not talked too much about like decision aids and those tools in this conversation, and also what makes a good decision. So we have a lot of questions that are unanswered and needs to get implemented in the practice, and we have lots of challenges in terms of time constraints and lack of accurate information. And I just want to end, give the panelists like 20 seconds to end each person. So for me, and also one key thing that I hear is that shared decision-making oftentimes it's not one event, it's a continuing process, and it's evolving over time. So starting it early will be really helpful in lots of the contexts. So I am a new faculty in family medicine, and primary care is really like the first contact point for many patients. So for me as a researcher, I want to go into the practice and see where we can bridge the gaps to see where we can intervene earlier in the process. So I'll go to Kristina. What's next? What's your final thoughts?
Yeah, thank you. I think from this discussion and just kind of across this entire SMDM conference this year, what I'm taking away is there's a lot more work to do, especially in terms of like, how do we bridge the gap from where we are in terms of our research knowledge and our, like what we're finding important and helpful for the patients that we want to help and the providers that we want to help, and ensuring that that somehow lands in the medical system, and that our patients and providers have the kind of expertise and resources that we have and find important. And so I don't know how to do that, but I think it's a lot more collaborations and bridging into areas where we haven't necessarily been yet. So yeah.
120 seconds. So, what I love about our discussion today and about MDM in general is it bridges the simplest sort of thing about bringing in, say, other professionals to start the decision-making process earlier, like we've been doing where MAs, medical assistants, give the patients the DA in our clinic. And that's like a breakthrough for us. Very technical, practical thing. But then we go all the way to the thing you raised there at the end, which is that we are helping people process grief. We are facing uncertainty about life and death, and that's through the decision-making process. So it's not like a technical thing. It's actually trying to bring in these enormous human challenges about human life, and somehow now in facing them and incorporating them in medical practice, which I think is just a great and deep challenge. And that was 30 seconds, I'm sorry.
I'm struck by the value of the conversation in the room today and how it included research perspective and clinician perspective and people speaking from a family member's perspective and from a system perspective. And that I think even when we do research that we talk about as being community-based or systems-based, we aren't including all those perspectives, and that we need to be broader in how we think about how we build research teams and build research questions so that we're actually affecting change.
Well, it's hard to be the last one, but so all well said. So it's kind of hard to find what I would like to say now. I think what I wanted to say was very similar to Ellen's, and the cases we provided, if you notice, it's not just about patient and the physician. It's not just dietetic. There's a whole different, family. There's, family meaning it can be multiple caregivers. It's not just the spouse. And it's the whole clinical team. Like it's not just the one provider, multiple providers, social workers, medical social workers, clinical psych. There's a whole team. So it's it's not just about the clinical factors, right? When someone is making a decision, there's the social factors, there's the cultural factors, there's the religious factors. So all these things makes it so complicated, but these are the things we cannot ignore, we need to look at. And I find that actually it is much more fun to study. So yeah, that's how I'm
All right. Thank you, everyone, for your participation. I hope you're going to take the thoughts and conversation with you to your practice and research and take small steps to make changes for better patient care. Thank you.
Keep the conversation going. Join the SMDM Shared Decision-Making SIG online for a complimentary webinar on Thursday, 9th October 2025 at 9 a.m. Eastern Time. Register for this interactive virtual event at smdm.org in Upcoming Meetings under the Meetings/Events tab, or find the link in the comments below.